We'll move into the open forum session, and I'd like to introduce the Vice President of the Nurse Practitioners Association, Natasha Prodenbala, and she will be your moderator.
So I thought it was kind of funny that typical nursing, we're kind of moderating ourselves. You actually don't need any help from me. Yes. So this is where we really want to hear, I personally am feeling a lot of support in the room, a lot of warmth, and we really want to utilize that and leave, like Mary Lou said at the beginning, around concrete steps. I think people are it's really important to think broad, and we also want to hear those things, but we also want to think about some concrete things that ARNBC can take away and the BC Coalition of Nursing Associations can take away from today in terms of what we want to do in terms of supporting. So how do we want to support the frontline nurses that are out there? How do we want to work at helping vicarious trauma and prevent PTSD from occurring? We've heard quite strongly, at least I heard today, that that is occurring and we're at risk. And I think that we really need to pay attention to that. And I think this is a great opportunity for us to come together and support one another in that. So I think there was a lot of things that people wanted to say, so I'm going to open it up to the floor for that. Now, ARNBC there's a coffee, has already worked with East Van Roasters to provide free coffee to frontline health workers. So we're looking for some of those kinds of ideas, but also some bigger ideas in terms of how we can support one another. So who?
I'm here representing PACE Society, a small nonprofit in the downtown east side. And I definitely hear what everybody here is talking about in terms of, burnout. And we've had this, we've already had the discussion about naloxone, so I'm not going to, well, I am. I'm going to make you guys go back there. So we've had VCH come and offer training to our members, which is fantastic. There are now 28 more people in the downtown east side that are trained on naloxone. But as a service provider, we're not able to get it. And we have outreach workers that are on the streets every 3 days a week, providing outreach and providing harm reduction supplies that aren't able to carry it and offer it to people. So in terms of, a solution for burnout, you have a huge resource of community organizations that would love to be partnered with you in this struggle, that are not able to get our hands on the resources to be able to help you. That right now, in order to get in order to get naloxone, you have to either be an opiate user yourself or have a close personal relationship with someone, like living with them. Otherwise, it's $35. And as an organization that receives no healthcare funding whatsoever, and has been working for 22 years to reduce barriers to healthcare, we can't afford $35 a kit in order to provide that to people. But we would really love to help you. So, I guess, if that may be a way to reduce some of the load.
Thank you for raising that. That's a really excellent point. Does anybody want to respond to that, or does anybody know if there's anything in the works to kind of change that such that we can work with our community partners better?
My name's Lori Campbell. I'm a nurse. I used to work at Insight. So I actually reached out on Twitter to the Toward the Heart folks and asked if there were any changes upcoming to the distribution pattern, because right now they're only funded, unfortunately, as I'm sorry I forgot your name. Brenna pointed out. And they said, unfortunately, at this point, the funding does not allow for that. So as nurses, I think that's somewhere that we can potentially raise our voices and help advocate for that change, because we know that naloxone is actually not that expensive. But the kits, when they're put together, and the manpower that it takes to make a kit and do the training and all of the supports that need to go around that distribution, that adds up the cost. So I think that we can advocate for wider distribution now that the scheduling has changed. And I think that that's somewhere that we can definitely partner with our community agencies who are willing to help and want to help us do the work, and allow them to serve the clients that they already have relationships with as well.
Thank you. Yep.
Just to add one more layer to that,
Yeah.
a lot of the members that we're supporting are not comfortable going to healthcare. Like,
Yeah.
the places, we can refer them to the places that are providing it, but for many of the members that we support who are street-level sex workers, who have had terrible experiences with healthcare providers, I'm sorry, guys, they're not going to go to you unless one of our support workers go with them, and we have to pay for that as well. So, you know, healthcare is already providing us with harm reduction. Why can't we get our hands on this?
Michelle? Oh.
I may say something that's not particularly popular, but that might be why I was invited. We have a bit of a disservice being done to the community in the sense that Narcan has been promoted as this great savior, and it's only part of the fix. And so a lot of people it's a double-edged sword. They either think that if they don't have Narcan, they can't help someone, or they think if they have Narcan, that's all they have to do.
Right.
And I really wish that we could start this all over again before Narcan was given out to so many people, and put emphasis on good first aid principles, ventilating a patient with a pocket mask. The difference that would make would have been amazing, and I hope we can catch up with it. For my son, I'm going to be teaching him first aid the first chance he gets. And I'd love to see in schools that standard first aid and CPR become part of the curriculum. But I'm going off on a little tangent here. It's not the answer I think you're looking for, unfortunately, but I do think that people have to understand that Narcan is not the only thing that fixes this problem, and that if you have a pocket mask or the ability to provide first aid, that will make a big difference.
That's a very good point. Thank you. Over there yet?
Hi, I'm Norjean from BCCDC. Thank you for those comments. We are going to have changes coming very soon, I think around mid-December, where friends and family will be able to get naloxone. So that'll be a change. It'll be on the Toward the Heart site. I think the definitions are still fairly loose, but I think service providers, you know, if we're saying friends, that gives us a little bit of leeway. So service providers like yourselves could probably qualify.
Yep.
My name is Ruby, and I want to speak to the point that you made about how individuals don't feel comfortable coming to healthcare. What are we doing about that? Because that's a big problem as well in terms of providing education. Because someone else also said over here, it's not that we want to be difficult, it's that we just don't have the tools and resources to support people. So I think that's also a big piece. It's not the immediate crisis that's occurring, but we need to look at that and address that.
Yep.
I would echo as well what she's saying. I'm an educator from Fraser Health, and we have a lot of interesting communities in Fraser Health with a lot of different values and beliefs. And I would say as nursing organizations, I would challenge that we need to come up with a stand about values and beliefs and judgment, because it's hard working in harm reduction when your peers are constantly challenging you to just be caring and compassionate. So it's exhausting teaching, and I'm teaching every day. But to be pushed by all my colleagues, that's we are supposed to be in this because we care. So what can we do to tell people about our standards of practice, and that we are supposed to be non-judgmental, that we are supposed to provide care and compassion to everyone? Why do not just teach us to be human to each other? So I'm not sure where that can come from and how we can make it systemically known that these are our clients, these are the people we work with, and everyone is human, and we have to treat each other like humans. So if there's anything we can do that might make it not that in the room, it's not just the communities and the non-educated or the judgmental, it's the nurses, it's the people that I'm teaching, that I constantly have to not know if I'm going to be attacked as a friend or a foe. when the comments come at me, because we are a very passive-aggressive workforce
Yep.
who will say to your face, I believe you, and behind your back stab you.
Yep.
So how do we deal with that? Because
Yep.
that's not helping us take care of each other when those of us that will stand up and say, I believe in harm reduction, are being stabbed behind the back by our peers and our colleagues. So
And that we need to create a whole culture change for that, right? And it starts with curriculum, then it starts at the policy table levels in terms of funding our practices as well, to enable us to not be so short-staffed, that we can really practice from like an equity-oriented model of care, not to be fee-for-service. Like, it's such a bigger picture in terms of that piece, but I really do think that it's one step at a time in terms of role modeling that behavior. And as an educator, you have so much value to kind of demonstrate that, right, to your students, and I think that we just need to kind of keep working at that. Leslie, did you have something?
I do. As I've said before, I'm not a nurse, I'm not in your profession, but one thing that has helped me immensely is to learn as much as I can about the nature of addiction. There's a book out there called The Unbroken Brain by Maya Salovitz, that, who is an addictions doctor who has been a person drug dependent herself. And it explains so much about addiction. And once a person knows how and why and wherefore of drug addiction, it is much easier to have compassion. I've had to look at my own stigma. Even though I'm doing this every day, I still have these thoughts that come up that I just think, God, where did that come from? And as you just said, it's a sea change. It's a paradigm shift about how we think about people who are drug dependent and what they need and how they got there. It's really hard to be dispassionate if you know these things in general about people who are addicted.
Did you have something, Mark?
Yeah, if I can just make one comment about how we want to scale up these kind of things outside the downtown east side. You're referring to Fraser, where some of these innovative interventions, Insight being the obvious one, have been built up over time and attracted people who are really passionate and interested and understand it. And to think that we can just take that model and now we're just going to do it throughout the province is going to be a hugely challenging thing, because people, both in my medical profession and the nursing profession and ambulance profession, like we all, there's a lot of work to be done in communities who haven't really confronted this, even though they should have been. And so as far as medical staff and nursing, I think in this kind of, we don't have time to make a whole cultural shift. That's going to take too long. But what I'd propose as far as physicians go, and probably even it's more important with nursing, is make sure you have some flexibility to actually attract the nurses that really want to do it. And that there's, what I'm concerned about even with these pop-up sites and things that are moving very quickly, if it all of a sudden gets very technical with unions and time and these, really it's what makes these work is the very low threshold, and nobody's asking these very technical questions. And I think really to canvass your membership and get a list of people who actually really want to do this, and provide the support and training, and not think that you have to have a whole cultural shift, because that's just going to take too long.
Yep.
And,
Yep.
So I don't want to sound like a one-pony show, but I'm going to say it one more time. If we get people with lived experience in the room, I think we're going to see changes happen. I'm involved in a project in collaboration with First Nations Health Authority called Compassion, Inclusion, and Engagement. And the whole idea is to get people with lived experience in the room with people who are providing health services and get them to sit together and talk about what their needs are and what sort of strategies would work in order to start to improve access to harm reduction services. And it's shocking to see service providers who are mimicking some of what some of us have said, sitting across the room looking all scared and frightened because somebody who's actually an active person living with drugs is sitting in the room with them at the beginning of this, and by the end of it they're sitting at tables together, talking, strategizing, thinking about what they can do as a collective to make a difference in accessing services. So if they're not sitting here with us, they're going to feel like they're kind of freakish people sitting off to the side and they don't belong. If they're sitting in the room with us, we're going to get used to it. I've seen the most judgmental nurses sitting in the room at the beginning of our engagement, and at the end of it, they're sitting there talking about how do we move forward together.
Thank you. Any other concrete kind of things that we can kind of take back and do? So I see 2 hands down there.
Hi, I'm Caitlin. I just left the injection site in September and I moved on to Vancouver Island Health Authority to be their harm reduction overdose prevention person on the ground in Nanaimo. What I am struggling the most with is best practice standards not being adhered to on the island. They are providing sterile cookers with the filters in them and still providing tampons and saying, here, filter your drugs through the tampons. The detox is prescribing benzos instead of opiate replacement. And all these things are happening from a systemic standpoint. I am a very compassionate, loving nurse. And I am not allowed to work as that because management won't let me call myself a nurse. Management won't let me work as a harm reduction provider and actually provide me with staffing, support, or any kind of information. Every piece of information I get because I'm still on the Insight mailing list. And that is something that drastically needs to be addressed because I don't have a union rep. There's no union reps within all of mental health substance use in Nanaimo, not one. And and so just best practice standards as well. It's like we can sit here and say that's a cultural shift that needs to happen, but at the end of the day, it's a systemic problem coming from the top down, in my opinion.
Yeah. And that level needs to be included in all of the discussions.
Yeah.
I'm Marjorie. I'm the clinical coordinator at Insight and Onsite right now. I just want to say that Insight's been open for 14 years. So this isn't something that's just happened. And I have just recently been invited to be involved in the development of best practice guidelines for nurses and supervised injection in Ontario because they're about to launch supervised injection services. So we are way behind in BC in terms of advocating and supporting our nurses and being able to deliver harm reduction services. It is, Tim and I think share the same emotional, I couldn't really participate fully in today because I feel like I'm failing my nurses as a leader. I cannot keep up with the work and the demand of the site right now. I don't have the support, we're being called specialty nurses. We have 3 days of orientation and on-site training and education because this is not being provided in our curriculum. There is a huge culture shift that needs to happen in BC right now. It's 14 years too late. And it's really, really frustrating to be so desperate for help right now and be hearing all of these great ideas and stuff and still know that nurses are not being provided with basic education on how to support our clients when they graduate, that I'm still going to have to do a ton of legwork to get those nurses up and ready when they come to Insight, that they, if we don't have educators like Dorothy bring their students to Insight, most students aren't aware, don't have exposure to what we do. It's really, really frustrating for us right now. And so there is lots that can be done from nursing organization level. CNA is involved heavily in accreditation of nursing programs and curriculum and education. That needs to happen now, making sure that harm reduction and good comprehensive knowledge of how to support clients in active addiction is being taught in schools like tomorrow, right?
Thank you. In the back there? Yep.
Hi, my name is Conrad. I'm a third-year nursing student at Langara College. And as a young adult, I spent a lot of time on the internet and social media. And what I've found is that there are still a lot of people out there who are, going back to what Leslie said earlier, who are stuck on the idea that addiction is a choice and that people are choosing to use drugs and making bad decisions and choosing not to get their lives back together, like you're choosing between pasta or sushi for dinner. And we, as the healthcare professionals, we know that's not true. It's because of trauma and social determinants of health and social inequality. So I guess what I'm trying to say is it's great that we have policymakers and health ministers at the top, upstream, who are making changes to help the people further down. But I think it's also something that nurses can do from the bottom up, is just engage with the public and start teaching them about social determinants of health and sort of when they sway the public, because if we can do that, I think it'll make the policymakers, their jobs easier, instead of having people who are like down here opposing to having new social housing, new injection sites. I don't want that in my neighborhood. So if they're more open to that, I think that would really help. Thank you.
Did you have something?
Yes, thank you very much. My name is Barb Shallian, and I'm president of the Canadian Nurses Association, and I want to say thank you very much for the invitation to be here today. The vibe in the room and the environment in the room is compelling and inspirational in many ways, and I think you're generating solutions that can be done and tomorrow, and not looking or blaming or pointing fingers, as Mary Lou had mentioned, about what should have been done in the past or what someone could have done to make it better, and to move forward with things that you can take with you when you leave the room today. I want to put forward a suggestion, and I may have to shut down my Twitter account after this, but I want to put forward a suggestion about how perhaps CNA could work for you and work with you, because we have been working very hard over the last absolutely more than a decade to talk about harm reduction in the environment of the federal government. And for some years, it's been difficult because we couldn't get a meeting, we couldn't have a conversation. But I'm here to tell you now that the doors are opening, and the doors are opening to nurses and nurses' voice on Parliament Hill. We've had, through many experts and support from specifically nurses in BC, Dr. Bernie Pauley, who represented Canadian nurses at the Opioid Summit that was held in Ottawa a few weeks ago. I was able to be one of the major signatories on that document with the Federal Minister of Health. So those little things that are happening at the federal level that CNA is pushing for you. 3 weeks ago, I had a meeting with the Prime Minister of Canada. That hasn't happened with a sitting Prime Minister in over 30 years. So no matter who the government is, and no matter what your political stripes are, the doors are open for nurses to talk about harm reduction, and it just thrills me when I hear the Federal Minister of Health saying that this crisis is a public health issue, and it's not blaming the victim anymore, and I really believe we can make some strides. CNA is a federation, so that's a fun thing to work in, right? To keep everybody happy. But we have jurisdictional members from across the country. We have CNA members in every province and territory. So this is our chance to be able to mobilize those jurisdictions, but also to keep me and CNA accountable as your voice at the national level. And I'm reminded of a very wise person who told me once that nurses work in the framework of primary health care, right? We all know about that. And primary health care is where the full scope of nursing practice intersects with the full scope of the human health experience, leaving no one behind. And if that doesn't describe harm reduction and work to look at social determinants of health, to treat people as individuals where they are and where their situation is, I don't know what else is. So today I'm asking you to, and I may regret this, but I don't think so, and I see Tanya giving me the hairy eyeball here because I know she will, to keep me accountable and to work alongside with your colleagues and your nursing colleagues and your support and ARNBC to move this forward. And if there's something that you think I should be doing as president of CNA at the national level, tell me, respectfully ask me to see if this is possible. We can phone up the Minister of Health now and ask for a meeting. We could not do that 2 years ago. That was not available to us. We can meet with senior policy advisors in the Prime Minister's office. We couldn't even get a sniff of that 2 years ago. So we can help at that level while you're doing what you can on the ground, at the coalface, however you want to describe it. But today I want to tell you, I have added to my list of nursing heroes, and you're all in the room today. Thank you.
Thank you very much. Michelle?
Hi, my name is Michelle Sims. I'm a nurse practitioner at Three Bridges Primary Care Clinic, and I have a lucky role in that I actually am able to do outreach 2 days a week. And the people that I work with are mostly youth 24 and under who are street entrenched. And what I have been doing for the last year is naloxone training, dispensing of naloxone, harm reduction teaching, overdose prevention and management teaching, and what else is left? I mean, that's basically been the focus of what I've been doing. But what I want to talk about is I have a few ideas. One is that I think there needs to be more outreach. I think it's great that there are places for people to go to, like Insight, this mobile emergency room that's happening, and other sites. But we need to be accessing people who won't come into clinics and to healthcare centers. And the majority of the people that I see, my clients, won't come in and see me at Three Bridges. They won't see me at satellite clinics, but they'll see me on the street. And I'm able to give them naloxone. The other thing I want to say is that I partner up with, this is just in terms of what someone was saying about partnering with other agencies. I don't go out with people from BCH often. I often have nursing students, medical students, residents. I go out with social workers from other agencies, or people from Covenant House Directions, which is Family Services of Greater Vancouver, and Watari Youth Services. And so these are the people that are reaching a lot of youth who are using opioids and stimulants and who are overdosing. And so my idea is that there are more outreach positions like this that have flexibility in their roles. And then I also wanted to talk about delegated function. I went to a talk at St. Paul's a few months ago, and Mark Lesician was there. He's the medical director or the medical health officer for the North Shore. And he talked about a delegated medical function for teaching non-healthcare providers how to administer and naloxone. So that's an idea. It was on the table a few months ago. I don't know if anyone can speak to this, but that's something for the people at PACE. You could be educated by an NP or a physician, and then able to carry naloxone and administer if someone's overdosing in front of you.
Thank you very much. Yep, back there. Yep, sure. Yep.
I just wanted to talk about the outreach. I work with the START program. It's a new program that came up in April. We do home detox. Please refer, please refer. Obviously not everybody is, depending on the person, but refer doesn't hurt. The other piece I want to talk about is, it's kind of like silly. I'm not good at politics. I don't know the solutions to this crisis that we're in. But this kind of brings me back to like my university days. I started a program with my friend, and it's called Unity. So it's like university and tea run together. We found that like a lot of people were struggling in exam sessions, like exam time and all of that. So what we did was we built a website, and we're like, put your name in, and we just met people for coffee. That was it. So I want to talk about being non-judgmental, and I think a lot of that is how can we be non-judgmental when you feel like everyone else is judging you at work even? So what if the issue is to talk to each other, right? So my question is there a demand or a need for a platform to simply talk to each other? And that being like you come together knowing that the other person also understands what being a nurse means, right? So I don't know, there is employee services and counseling, but I do want to touch on that burnout piece because I'm concerned about it as well. We do a lot, and even from just like this energy in the room, it's like we're still concerned about how do we fix this and not looking in. So I just want to kind of, yes, turn that and see if that, like a platform, just to meet each other and simply unload and vent if that is something that you guys think is cool or needed, you know? So I'm going to put that out there. Let me know if that's something that you think is a solution.
I know I attended for some time, the CDC street nurses did do kind of a lunch thing, but that kind of fell apart. Anyone from the CDC that knows about that? But and I really appreciated that because it was really a good time for us to kind of, and to learn about services. So to really figure out, oh, you're doing that and you can provide that. And I didn't know you did, in-house detox. And I didn't know you did outreach on the street. And, how do we, and then people didn't know about our clinic at Habit in Hastings, which is women's only safe space. And I think I agree with you. And I think that maybe this is a call to kind of recreate something like that. Yeah. Okay.
Sorry, just a quick note on that line of thinking. In the ARMBC, we have a number of communities of practice, and these are groups that have specific interest areas. So it's an infrastructure in the interweb that permits us disparate nurses from across the province to connect on a specific issue. And so we're suggesting creating a community of practice around this issue. We have many of your emails, and so you'll get an invite inviting you to this, because really we need to continue this conversation beyond this morning. And anyone who hasn't signed up or just signed up at the door, staff is saying, just give us your email and we'll make sure you're added to this.
That's a great idea. Thank you. Yep.
Howdy, my name's Damon Deline here. I'm a nurse educator from Prince George in mental health and substance use. I'm an educator at UNBC and a northern rep for ARNBC, because in the north we are few, we cover lots of area, and we wear many hats. Tonight I'm going to jump back on this plane, and Prince George is one of the communities who just opened up one of these not safe injection sites. So I get back on the plane tomorrow. I got to go to work and figure out how to provide practice support for nurses practicing in this incredibly daunting area. I came up with a list. This is about things to do tomorrow. I'm going to connect with Sally, a former classmate of mine, see if I can't get some resources, because this is quite frankly out of my scope, and this has to quickly get back within it. I'm going to schedule a new trauma-informed practice course. We have quite a robust educator in Prince George, and it's clearly called for. And I'm going to see if we can't get some students in the injection clinic. I think have some pull there. So I got my card if anybody wants to keep me honest and make sure.
We heard the three things.
Yeah. Anybody want to take my card?
I'd like to take your card. I just want to make an offer. Again, I'm from BCCDC, and one of the things that we're interested in doing is supporting nurses out there in the regional health authorities or in community who are doing this type of work. And we'd like to, thanks very much. Okay. We'd like to make sure you get it done, but I think more than that, we'd like to be able to support you. So this is kind of an open offer. I don't have a card, but you can certainly just connect with, just call the BCCDC and check with our professional practice office or the CNO, and we'll make sure we can link you appropriately.
Thank you. Did you have your hand up before? Yes. Yeah. Oh.
Hi there, my name's Christine Sorensen. Am I on? Can you hear me?
Yep.
Yep. No, it's okay. Thanks, Adrian. My name's Christine Sorensen. I'm the Vice President for the British Columbia Nurses Union. And I found this morning's conversation very enlightening, particularly the stories from the nurses who have worked at Insight or who have lived addiction stories. Those are most telling. BCNU is very proud of the fact that we were there at the very beginning with Insight, and I remember standing with Tim on the steps of the Supreme Court when the Insight decision came down, and we're very proud to have always championed the work of the nurses at Insight. there were some issues raised earlier that the union really hasn't been stepping forward. We often advocate at multiple levels and very quietly in the back. We have continued to advocate. We've been hearing from our nurses constantly, and I encourage the nurses who feel that they may not have a voice at their worksite to speak up and to bring forward. I'll hand you my card. Happy to have you come forward. I'm very concerned about the issues around nurses and their inability to practice to their standards. That's a concern because not only are they putting their license at risk, but patient care is not at the level that needs to be provided, and that's very concerning. We are all here as nurses, for those of you who aren't nurses, but for those of us that are nurses, we're here to provide the level of care that our patients, and these are human beings, these people need and deserve, and they should be no less because of their addiction history. As nurses, we all have a professional responsibility to document. We have concerns like that, and we now have a nursing policy secretariat as a result of the collective agreement language that we achieved in our last round of bargaining that gives us a venue to address these standards that are being addressed. We also ask nurses to provide us with the opportunity to document where staffing isn't appropriate, and I speak to your comments, Mark, around the need to have creative solutions, flexibility, and the union is always about creative solutions and flexibility as long as we're there in those discussions and making sure that our nurses are well protected. We advocate every day to make sure that our patients get the care they provide, that our patients are safe, but that the nurses, like the nurse that's sitting beside me, isn't working 16, 24-hour shifts, that has the staff that they need. And we're looking for our community. We're looking to our community partners to be given the supports that they need. But we're also very clear that creative solutions include other healthcare professionals like the nurse practitioner that spoke, pharmacists, respiratory techs, physicians, first responders. We spoke out yesterday at a public forum with the firefighters who are first responding with our ambulance colleagues. We need more people. We certainly are looking at staffing, and the union is here to support the nurses. We will be meeting with them regularly, looking for what they need. Letters are going to the Van Coastal Health leadership. We're talking to the Ministry of Health. We will do what we need to do to make sure that the nurses are able to provide the care they need, and that they're safe while they're doing it, and that we don't burn out another nurse. And that's not only at Insight, but we have in multiple sites around the province. So that's my commitment as a leader in my organization.
Thank you. And I can say that the ARNBC and the BC Coalition of Nursing Associations, that's what today is about, to work with, for all of us to work together on that and on your behalf. So certainly, same with CNA, everyone's here to kind of work and really come up with some solutions and work together. So who else has, so back there?
Thank you. I was just wondering if we could leverage the experience in this room to move this away from the Vancouver area and into the rural and remote setting.
Yep.
How do we support our rural and remote colleagues who don't have access to this amazing level of groupthink and brain trust?
Yep. And I heard this, what are they called? Community of practice groups, which would be more online. That's a good way to do it. Any other solutions? Do you have any ideas or any other rural, how to stay connected? Yeah, go ahead.
Thank you. My name is Shannon Simcoe, and I'm an intensive case management nurse in Courtenay, which is way up Vancouver Island. And so I've been sitting here listening very intently, and the same idea keeps recurring in my head. We need more nurses. We need more nurses. We need more nurses. So best of everything to all the Insight nurses, please take care of yourself. You do amazing work. I do nothing even close to what you do. I work in a community setting. I'm an outreach nurse, but I can barely get my work done at the end of the day. And nurses across every field are working to the same capacity, not taking their breaks, barely getting everything done. I haven't had a chance to do education in 2 years. I haven't gone to a staff meeting in 2 years. And I used to do that regularly because the complexity of the clients that I work with who are substance affected, homeless, complex medical conditions, we're just on the ground running. And I have a fantastic job. I don't work overtime. So I'm stretched. And we hear that people who are in the midst of this crisis are stretched. So I can't say it enough, and I don't know who can even get us more nurses, but I think that would solve a lot of the problems that we've been talking about today and keep our nurses healthy and safe, which is so paramount.
Thank you. I just need to ask if there's anybody on the conference call that has any questions. Do they just get streamed down from above? Okay, I take that as a no. Anybody else in terms of engaging rural and remote nurses and other frontline staff? Yep.
Hi again, I'm Sally. So I'm from the north. I did my schooling in UNBC in rural and remote nursing. I agree we need more nurses for sure. And one thing we can do, we're resilient as nurses. We're creative. We can leverage the skills we have. So in regards to naloxone, what we're doing here in Vancouver is train the trainer model. And I can offer personally, I know we have limited time, but I can offer to people in the north as well. We're developing an online naloxone administration course. I'm sure we're more than willing to share that and to have access to that to people in the north. As well, we can share resources. I'm not, haven't been in my role long enough to have a card, but you can get my email after. I've got a lot of great teaching resources and connections that way. And we can also do an online podcast kind of teaching for naloxone and to teach what we're doing here, what's working, what's not working, and to connect everyone in the north. Thanks.
Thank you. Yep.
Just to add to that, I think it needs to be bigger than just naloxone. Like we've already kind of touched base on, like that's not the end all be all. Like I think a podcast would be a great idea, but cover everything. Like how do you look after yourself when you're working 16-hour shifts? How do you properly give breaths? And like has the CPR standards changed, which they have, and maybe we haven't updated those yet. I don't know. Like those kinds of things. I think education for these rural communities is key. And I'm really lucky that I came from the VCH background I did. With so much support and so much education and insight, that when I got to VHA, having no harm reduction course, no support, no clinical nurse educator, no nothing. So I think that those kinds of pieces where I can pursue myself, like online, that are low barrier and kind of framed in that harm reduction way, I think would be so beneficial for engaging. Even like the nurse that's working in a medical surgical unit, that's like, hey, I heard this really rad podcast, like listen to it. Like that kind of thing I think would just be so important for engaging nurses because you don't know what you don't know until you know it. And that's really important, I think.
That's great. Yep, in the back.
I just want to address the rural and remote. I'm Chris Westland from First Nations Health Authority. I'm a clinical nurse specialist, mental health. We have 203 First Nations communities in BC. We have very limited nursing education staff, probably way less than the health authorities. Our harm reduction program with naloxone is in over 50 communities. Our nurses, over 200 nurses in the last 2 months have been exposed to the naloxone and breathe education. And one of the really great programs is Toward the Heart, and I encourage you all to get your nurses online in rural areas. They will send the educators out for free to your communities to do the training. And I just want to comment on one other piece that was brought up on how do we change the culture in nursing. Well, the thing I haven't heard here today is that we have to have compassion for each other. Every nurse has a story. And sometimes this is not a cardiac arrest or diabetes. This is a gray, murky area. People who use substances. It affects every one of us in our families. So if a nurse is unable to react in an appropriate way to an overdose crisis or someone in that type of crisis, they have the right to step back and say, can someone else do this? Because I just lost my sister to addiction last week. And with First Nation nurses and the amount of trauma they've experienced, I've had them in tears because they feel ashamed that they can't step up because they lost someone recently. And I really admire what you said, Tanya. Because when you start undoing those layers as a nurse who's burned out,
Yeah.
it is really hard work. And so I encourage you to have compassion for your fellow nurses, and to remember everyone has a story. Thank you.
But supporting each other. Judy?
Judy Darcy, Opposition Spokesperson on Health. I've heard everyone has spoken to issues of staffing, needing more nurses, needing more paramedics, needing more safe drugs, mental health, housing, treatment programs, which at the end of the day is about priorities and resources. So I want to also strongly encourage that you communicate your experience, your feelings on this, what you see as the urgent necessity for more action and more resources to every single MLA, urban and rural, across the province. The House isn't sitting now, it didn't sit this fall, it will be in the spring. There's a budget that's being prepared. And at the end of the day, this is about resources to do all of the things that people in this room have spoken about, so that we really do treat this issue the way we would if it were diabetes or heart attack or, all of, I want to also offer, I don't have enough cards to give to everybody, but my colleague Sue Hamill, who's here, who's the spokesperson on mental health and addictions, can I give them your email address as well as mine? There's a standard formula for your MLA. It's very easy. First name, period, dot, last name, dot, MLA at leg.bc.ca. So Sue Hamill is SUE.HAMMELL.MLA at leg.bc.ca. And I am Judy, JUDY.DARCY.MLA at leg.bc.ca. So we have been advocating. Our voices sometimes aren't heard in the media, but we certainly have been, and we will be in the legislature advocating. But share your stories with us, because when we can tell the human story, we can be far more effective.
Judy, what would you say is the best way to do that? So I think a lot of us struggle with that, right? Like, how do we, can we get a presentation that we saw today on what's going on at Insight? Can we do that to the Minister of Health? Do we write letters? Do we sign a petition? Like, do we go meet individually with our MLAs with a form letter? It's sometimes hard to know, right, where your energy is going to be best put.
I think the most powerful is to go to every single MLA
in person
and tell the story, and bring people who have lived experience as drug users, as people with addictions, as well as healthcare providers, and tell that story together, and tell them, but always be clear what it is that you think is needed.
Yeah. Okay, that's great. That's very helpful. Thank you. Yeah, in the back.
So I just wanted to answer your question about concrete things that could be done that could make us feel more supported. I'm a nurse in the downtown east side at various sites. The way that lines work, or permanent positions, is that you're generally in one site. I can't imagine taking a line right now, if it was full-time, knowing that I might see 10 overdoses every single day. But if we were able to balance that with 50% in one site, 50% somewhere else, that would be much more manageable and probably more cost-effective in the long run, because if I go on disability, we're all paying for it. Secondly, WCB is not a very friendly organization to interact with. When we talk about people not feeling safe going to healthcare, that includes WCB. So I know, Brenna, you were speaking about ER and primary care, of which I agree, many people do not feel safe accessing care from us, but it's also us that don't feel safe accessing our own care. It involves a computer program. You have to state your gender marker. You have to state your legal name. It is available online for anybody with that password to see. And that's the same for our patients. So if somebody says that they are a drug user and that gets written down by a psychiatrist, pretty much every single professional after that will copy and paste that statement. It doesn't matter if it was true or not, whether it should be in there or not. the rest of their lives it's going to be included, and that is including the stigma of that individual professional. When I think about my clients and how simple it is to work with them, some of the most genuine, honest, transparent, caring people I have ever worked with, and yet we sit here and call them medically complex. And I feel really uncomfortable with that because to me it seems very normal at this point. Been part of the community for 10 years. I expect that most of my clients at some point will have faced stigma in the medical system. I expect them to at some point have up to 10 different mental health diagnoses that may have fit that snapshot in their life. And that's just normal, and I have to filter through all that and say, okay, who am I actually working with, and what do they need, and how can I play the system to actually get their needs met? Because I don't always feel that I can be honest when I'm working with outsiders. When I think about the trans women I work with and what they put up with on a daily basis, I don't feel that a lot of people in Vancouver outside of the downtown east side can even imagine what they're going through. We have sexual assault services that go to the ER, but that's for people that have an unusual event of a sexual assault. They're not talking about people that go through it every day and no longer go to the ER. Yeah. And I wish our bodies that are in power could actually acknowledge that when we have the conversations, we're not including the stories of what is normal. We're including what people view as normal and abnormal. And that I don't know where to send somebody to detox who wants to go to detox, not a forced treatment, but maybe they have a medical complexity, which is physical in nature, but our detoxes only take people that are able-bodied.
Yeah.
So how do I even have a conversation to advocate for that when, like, it feels sometimes impossible, and that's where I'm burning out. It's not with the clients in particular. And I don't feel that I have the ability to speak to that when I go to certain professionals for mental health support, when I call WCP, because they don't recognize the things that I'm having trouble with, and the people that do are my colleagues. But if I don't have time to meet with my colleagues and sit down and actually convey what I'm upset about, then they just see me getting more and more jaded.
Yeah.
And so those meetings that we talk about, they need to be more regular if possible. I know at one of my work sites, we used to have once a week 3-hour education sessions, which almost worked as a form of counseling because we'd come together and see each other. And if there's any way that that can happen, I would certainly welcome it. Or having a float nurse that works at Insight, and then like we know that there's nurses needed every day. There's somebody saying we're short. Why is it a reactive thing? Why are we not saying, okay, let's hire a nurse, they're full-time, we don't know where they're going to be yet, but we know their hours, and let's just go to.
Okay.
Those are just my thoughts.
That's great. Those are some really good concrete things that we can take away. That's great. Yep.
I'm actually going to just pass it over to my colleague in the front who's had her hand up for a really long time, longer than me, and then I'll go next if that's okay.
For the nursing associations and bodies and asking what you can do, I think it's great. I'm sure lots happen in the background that I don't know about, but I think we get political support when we get public support.
Yeah.
And every morning I listen to firefighters with a very concentrated action on TV, on radio, really bringing public awareness and supporting their members and talking about the needs. But I don't really see that from my bodies. I see it from Mary Lou, I see it from Len, I see it from people that I work with, but I don't see my body out there asking for more funding and more nurses and more support. And as we said, nothing happens without funding, and nothing happens without awareness. So I think it would be great, talking to your MLA, perfect. But if we don't have the support of our public, we're not going to get the support of our politicians, because you go with the public. So, thank you.
Thank you. Did you? Yes, I've seen your mic on. Sorry. A lot of people.
So I excuse me, I just wanted to bring it back. I know we're going sometimes kind of narrow in our discussion, and we really have, sorry, a better word would be focused, very focused. If you'll permit me for 60 seconds to bring it back out to primary health care. And where was I going with that? So I'm an outsider with VCH. I'm an educator at BCIT, so I'm not inside getting all of the details around the second generation report and the enactment of the second generation report. But I do know from my colleagues, from my students who are graduates and working in the services in the downtown east side, that we're actually narrowing outreach nursing, and we're getting the integrated clinical services, if I've got that correct, with fewer resources going into outreach nursing. And I guess I'm hearing, and I know the evidence of outreach nursing working, and I know the communities and the populations that we're working with, no matter how well the integrated clinics work, we still need outreach nursing. And so I'm wondering if we've got BCNU sitting here, we've got ARNBC sitting here, so I'm just pulling together what I'm hearing and asking, without a concrete suggestion, that we take note of that and that we advocate for our outreach nursing teams, whatever that looks like within the new integrated services. Thanks.
Okay. Okay. Yeah. Oh yes, I promised you. Sorry. And then, oh, sorry. This is the last speaker. Unfortunately, I've been cut off.
Okay. Thank you so much. Dawn Tisdale. I'm a new grad. I'm the current past president of the Canadian Nursing Students Association and the new grad student lead at ARNBC, doing a contract with them. So I just want to go to the focus of students and new grads, because we have an extremely high attrition rate for new grads, for RNs in BC right now, and I think everyone has spoken to why that is. And just hearing the personal experiences of the Insight nurses today, like my heart just hurts so much. And I think for new grads, you know, like you guys are asking for workers, and I know for myself, just working on a medical unit, the amount of trauma that I've already felt, and all of my nursing colleagues that are working with me, just as a 2016 grad, I've already sought out and paid for my own counseling services to get through it. And I think, you know, like obviously the things in place currently that we have for nursing isn't good. Like I was passed, all of us in my graduating class were passed the EAP cards for, you know, I don't even totally know what that is, in orientation, and there you go. And so my point being, and I'll get to it, is that, you know, so we might not be able to completely change the previous culture, but we can do things better to put into place to change the new culture happening. And so like, the fact that like brilliant minds here are having trouble describing what self-care looks like, and it almost feels victim blamey to say like, you know, you guys need to practice self-care. It just boggles the mind, like how there isn't somebody in place at Insight and for people dealing with this crisis in this really traumatic event, that we don't have like counseling and proper services in place. And it's not fair to the new generation of nurses. I mean, if it's so hard to advocate for ourselves, but I would just ask that maybe we think of the new grads coming in and the attrition rate and how we're having a nursing shortage, that we need to figure out concretely what that looks like as far as self-care, and we need concrete ideas, not just talking about it. The other thing I just wanted to bring up was I come from the Comox Valley. We just had a very successful coalition, a grassroots of, and we're still doing it, on how to deal with the homelessness issue. And I think that this is a lovely platform today, but we're clearly just scratching the surface. So I very vulnerably am putting myself out there to say that I think that we need a coalition that meets regularly to deal with this. And we have brilliant minds that know clearly what to be done. So I would volunteer myself to do that in any capacity and start a coalition that meets regularly. The other thing, and sorry, I swear I'm going to stop at this last one, but I also feel like today it's been kind of suggested that we're all very much preaching to the choir. So I was just curious if anybody knows, the first time I in a rural again, Comox, heard about this in school, there was an excellent documentary, and of course I can't remember it, about street nursing in Vancouver, and what is it? Bevel Up, thank you, that's it, Bevel Up. And it impacted my whole class. We had leadership projects on it, And so how, like, is anything like that happening about the current crisis? And is that a way to get the general public, who are voters, to be more engaged in what the issues are? Because again, it's wonderful that we're all talking about it amongst ourselves, but we need the buy-in from the people who don't engage or believe in harm reduction. And so how can we appeal to those people? And who are they? And how do we access them? Thanks.
I'm just, Mary Lou, she wants to quickly
jump in.
Do I just
press this? Okay. Yeah, I mean, I think the reason I'm the outsider, so I've been trying to stay quiet, which is really hard for me. But I think what's been really hard for me is I've been thinking about this every day, because after 4 days of spending it with nurses at the front line, I couldn't shake why it was so hard to make a case for support for nurses, because we've done that with SARS, H1N1, the flu. With SARS, we had hotlines, counseling, we had urgent teleconference like meetings every week. It's just, all this has been done before with other crises. I don't see why we need to explore solutions. We've done this before. Let's just deploy some of the same things that worked now, not in a month. And it's the holidays, and I will not wait for us to all enjoy our holidays while the nurses are doing and going through this again, all over again over the next month, which, the checks coming in and everything. It's not acceptable. And so I want us to leave this meeting feeling the urgency that I've been feeling after spending just 4 days with these nurses. And wake up in the morning and think about them, and go to bed and think about them. And if that makes you feel uncomfortable, well, just imagine doing the work. So this is the message I would leave you with.
Thank you very much, Marley. So I'm going to pass it. Thank you very much for everybody's comments. Sorry I had to cut them off. They were very well articulated, and I think gave us a lot that we can work on for sure. And I'm going to pass it back over to Jacqueline.
Thank you, Natasha. And thank you, everyone, for a very wholesome and robust discussion. And I'm now going to ask Zach back to the mic to do a little summary before we break.
Thank you. I know we're all probably have places to go. I just wanted to kind of encapsulate this, because we're probably all wondering, what now? Isn't that nice? We spent 3 hours talking about this important stuff, but this is obviously just the beginning. And so, I want to acknowledge we do have 3 groups here that are very invested here. We have the CNA, we have the VCNU, and ARMBC, as well as the other associations, and this is really an all hands on deck situation, and I'm hearing commitments from all groups, and really this is something that we are best suited for success if we all work together on this. I mentioned the capacity to build an online platform with a community of practice. I also heard a question around how do we engage with our MLAs, and it can be a little ponderous, so it would be easy to create an email letter portal to MLAs with their appropriate titles and who is the best ears to hit with this. I want to mirror what Barb shared about relationship with government, in that we've certainly have nurtured and fostered a rather collegial and respectful relationship with government, with the Ministry of Health. We can call the Minister's office and get a meeting. We have a great relationship with Ministry of Health, as well as the appropriate opposition critics. In fact, they're in attendance right here. Minister Lake wanted to be here, but he's in a cabinet meeting. But I think that we need to repeat this forum. This needs to be a full day. There are more people that ought to be here that aren't here. As well as a relationship with the CNOs. Hey, Glenn. I mean, there are aspects of relationships with health authorities that need to also be tied in here. And this needs to be a long-term solution here. This isn't our one-day forum. Some of us are going to do some touring and visiting with the safe consumption sites to witness what's going on for some frontline nurses, but it's not a photo op and a handshake and a cup of coffee and see you later. This is the beginning of a commitment that we need to make. And I wanted to say we need to commit to continue working with the people who are using drugs. I was so appreciative for Jordan to come in. We will work with Vandu. I'll make a plug for Redone, which you probably haven't heard of, but it's a rural empowered drug users network in my area in the Kootenays. So there are rural components to that as well, and absolutely they need to be at this table. And lastly, I just want to thank the frontline nurses who are doing this and have been doing this for months. I see the spike in the curve there. I mean, you've known for ages that this was coming and have alerted us, and apologies that it's so quick to mobilize action to crisis, but I feel like we're on the edge of action now. And so it's my commitment that we will continue to work on this with you.
Thank you. I'd now like to invite Anita Dixon, President of the LPN Association, for closing remarks.
So I've been given the quick task to close it so that everyone can go, so I want to thank you for that. My name is Anita Dixon. As you've heard, I'm the president of LPN ABC, but I wanted to say, as you've now courageously shared your stories, and I've been nervous, but I will do mine, is that I'm a daughter of a loving spirit. My mother was a drug addict, and when I lost her when I was 8 years old. I lost her both physically and emotionally, and she passed away in a homeless shelter near Oppenheimer Park in 2004. So this really hits home with me. It's definitely something that has shattered, and we all have our stories. So what she taught me was acceptance. And that has been my value that I do all the time when I come and I treat people, when I see them coming through the doors. So that's my story that I wanted just to give to you, that I've been wanting to say. And then I have the honor of saying thank you to all of you who have participated here today and given your stories and told and given your ideas. Your willingness to share your struggles, your ideas, your recommendations will help inform our work as you're going forward. And we don't want today to be a one-off. We've heard that. Our commitment is that, and we definitely are going to be working together. So we will continue to connect with you whenever we can. We welcome you to reach out to us, and we definitely, our email address and our website. Many thanks to all of you who have contributed your time and efforts to come here today. It means a lot to the coalition and to all of us as nurses and caregivers. It's been a challenge to pull this together in such a short time, so I want to acknowledge that. We feel that as we can move forward, so I want to give a special thanks to the ARMBC staff. To pull something like this together in 10 days is absolutely amazing, but it was so important for us. We will put notes together, as Zach has done a great summary, and he will definitely pull that forward. And thank you again for your participation and support. As we assure you, this is not the first time. It will definitely be the beginning of a long time. Thank you.